Welcome, Doctors Hissa. Today, we are mastering the classification of cardiomyopathy, a topic that is absolutely critical for your NEET PG rank. This is not just about memorizing definitions. It is about understanding the structural and functional patterns that the examiner will hide inside clinical vignettes. We are going to break down the complex classifications into high-yield concepts, moving from the basic definitions to the advanced genetic phenotypes that have recently become favorite testing grounds. By the end of this session, you will be able to look at a patient profile or an echo report and instantly recognize whether you are dealing with a hypertrophic, dilated, or restrictive pathology. Let's begin our preparation. Let us start with the definition, and please pay attention because this is a common trap in the exam. Technically, the term cardiomyopathy describes a primary disease of the heart muscle itself. This means we are originally excluding myocardial dysfunction that results from other cardiovascular diseases like blocked arteries or bad valves. However, in common clinical usage, you will hear terms like ischemic cardiomyopathy, valvular cardiomyopathy, or hypertensive cardiomyopathy. For NEET PG, you must distinguish between primary intrinsic muscle disease and these secondary causes. If a question describes a patient with global hypokinesis and a history of multiple myocardial infarctions, that is secondary ischemic cardiomyopathy. But if they describe a young patient with heart failure and clean coronary arteries, your diagnostic instinct must immediately switch to primary cardiomyopathy. We organize these diseases using the traditional morphologic classification, which divides them into 4 major phenotypes based on what the heart looks like and how it functions. First is hypertrophic cardiomyopathy, or HCM, characterized by wall thickening. The second is dilated cardiomyopathy, or DCM, defined by enlargement and pumping failure. Third is restrictive cardiomyopathy, or RCM, which is about impaired filling or stiffness. And fourth is arrhythmogenic right ventricular cardiomyopathy, often called ARVC or arrhythmogenic cardiomyopathy, where muscle is replaced by fibrofatty tissue. This framework is your roadmap. When you read a question, ask yourself, is the wall thick? Is the chamber big? Is the muscle stiff? Or is there an arrhythmia? That morphologic clue is your first step to the correct answer. Now focus intensely here. This slide contains specific numbers you must memorize for entrance exams. For hypertrophic cardiomyopathy, the diagnostic criteria rely on septal thickness. In men, a septal thickness of 15 millimeters or more is diagnostic. In women, the cutoff is 13 millimeters or more. However, and this is very important for NEET PG, if the patient has a family history of HCM or a positive genetic test, the threshold drops to 13 to 14 millimeters. Do not miss a diagnosis in a relative just because they haven't hit the 15 millimeter mark. Also, look at the ejection fraction. In HCM, the left ventricular ejection fraction is typically normal or even high, usually greater than 60%. The left ventricular chamber volume is normal or small. If you see a thick heart with a low ejection fraction initially, pause and rethink, because classic HCM starts with hyperdynamic systolic function. HCM is not a single entity. It presents in distinct patterns of hypertrophy. The most common pattern, and the one you will see most often in exams, is asymmetric septal hypertrophy, where the septum is disproportionately thicker than the free wall. You might also see inverse or sigmoid septal hypertrophy, which involves the basal septum. Concentric left ventricular hypertrophy involves symmetrical thickening and can be easily confused with hypertensive heart disease. Finally, there is apical hypertrophy, which predominantly affects the tip of the ventricle. In an exam vignette, if they mention giant T-wave inversions in the precordial leads, you should immediately think of this apical variant. Recognizing these patterns helps you distinguish true HCM from other causes of a thick heart. Differential diagnosis is where the rank deciding questions live. You must be able to differentiate HCM from conditions that mimic it. 2 common physiological challenges are athlete's heart and severe chronic hypertension. Both can cause thickening, but athlete's heart usually resolves with detraining, whereas HCM does not. You must also watch out for metabolic mimics. Storage diseases like Anderson-Fabry disease, PRKG2 mutations, and Danon's disease can look exactly like HCM on an echo. In older patients, if you see asymmetric septal thickening, you must exclude amyloidosis. A classic NEET PG trap is an elderly patient with what looks like HCM, but also has neuropathy or proteinuria. That is likely amyloidosis, not classic sarcomeric HCM. Here is a concept that tests your understanding of disease progression. While we said HCM typically has a high ejection fraction, about 5% of patients will evolve into what we call HCM with reduced ejection fraction. This is the burned out phase where the heart fails. In this stage, the physiology becomes more restrictive. The wall might thin out slightly, and the ejection fraction drops below 50%. This represents a major change in management. If an exam question describes a patient with a long-standing history of HCM who now presents with signs of pump failure and a low EF, do not assume the initial diagnosis was wrong. They have simply evolved into this rare advanced phenotype. Let's shift to dilated cardiomyopathy, or DCM. The definition here is all about systolic failure. DCM is defined when the left ventricular ejection fraction is less than or equal to 50%. However, most patients you see clinically will present when it has already dropped to 40% or lower. Along with the low EF, there must be dilation. We look for a left ventricular end diastolic volume greater than 112% of normal, or a dimension greater than 95% predicted. For your exams, remember two thresholds. Ejection fraction less than 50% establishes the diagnosis, but ejection fraction less than 40% is the typical threshold where we initiate aggressive traditional heart failure therapies. Continuing with DCM, we have a critical high yield number for device therapy. If a patient with DCM has a persistent ejection fraction less than or equal to 30 to 35%, despite optimal medical therapy, they meet the threshold for a primary prevention, implantable cardioverter defibrillator, or INI-CET. This is to prevent sudden cardiac death. You must memorize this 35% cutoff. Another important concept is the mid-range transition zone. DCM is dynamic. With treatment, a patient can undergo reverse remodeling, where the heart shrinks and the EF improves. This is called remission. Conversely, they can deteriorate. So an EF of 40% is often a snapshot of a patient either getting better or getting worse. Now we arrive at restrictive cardiomyopathy, or RCM. This is the least common phenotype but frequently tested because the hemodynamics are unique. In RCM, the primary problem is diastolic dysfunction. The heart cannot fill properly. The wall thickness is often increased, which is why it can be confused with HCM. But it can also appear normal. The key differentiator is the chamber size. In RCM, the ventricles are usually not dilated, but there is marked atrial enlargement because the atria have to push against that stiff ventricle. The ejection fraction is usually only mildly reduced or normal. Clinically, these patients present with right heart failure signs like ascites and edema that seem out of proportion to their left-sided symptoms. If you see a patient with massive biatrial enlargement and normal ventricular size, think restriction immediately. When determining the cause of restrictive cardiomyopathy, the thickness of the ventricular wall is your most powerful differentiator. In a typical exam vignette, if you see a patient with restrictive physiology, meaning severe diastolic dysfunction and dilated atria, but the ventricular walls are markedly thickened, you must immediately suspect infiltrative diseases. The classic answer here is amyloidosis, or in younger patients, inherited storage diseases. In contrast, other common causes like radiation fibrosis, scleroderma, or doxorubicin toxicity typically cause restriction due to fibrosis without that massive increase in wall thickness. So, thick walls with restriction equal infiltration, while normal thickness with restriction points toward fibrotic or drug-induced causes. Here's a diagnostic trap that frequently catches students off guard regarding sarcoidosis. Although textbooks traditionally list cardiac sarcoidosis under restrictive cardiomyopathy, in clinical practice and on modern exams, it rarely presents as a pure restrictive phenotype. Instead, sarcoidosis more often presents with regional wall motion abnormalities, a dilated cardiomyopathy phenotype, or predominant right ventricular involvement. If a question suggests sarcoidosis, do not just look for restriction. Look for conduction blocks or ventricular arrhythmias, combined with wall motion defects that do not fit a coronary artery territory. You must also rigorously exclude structural heart disease, like coronary artery disease, before labeling a patient with these primary myocardial defects. We are now moving to Arrhythmogenic Cardiomyopathy, or ACM-TIT. You likely learned this as ARVD, or arrhythmogenic right ventricular dysplasia. But the terminology has evolved because we now know it affects the left ventricle too. The fundamental pathology here is the replacement of normal heart muscle with fibrofatty tissue, driven predominantly by genetic causes. We classify this based on which ventricle is hit the hardest. ACM-RV for right ventricular predominance, ACM-LV for left ventricular predominance, or biventricular ACM. This shift in terminology is important because the examiner may present a case with left-sided involvement that looks like a dilated cardiomyopathy but is actually a genetic arrhythmogenic condition. For the classic right-sided presentation, now called ACM-RV, we rely on the modified 2010 task force criteria. This diagnosis is not made by a single test, but by a combination of major and minor criteria involving structural changes, histology, and ECG findings. The hallmark description you need to recognize is fibrofatty infiltration, leading to aneurysmal dilations and wall thinning in the right ventricle. Clinically, these patients present with life-threatening ventricular arrhythmias that arise from the right ventricle. A crucial differential diagnosis to keep in mind is cardiac sarcoidosis, which can mimic this condition perfectly with right ventricular involvement and arrhythmias. So look for systemic signs of sarcoidosis to tell them apart. Let's focus on the left ventricular variant, ACM-LV, because it changes your management rules. In standard dilated cardiomyopathy, we usually wait for the ejection fraction to drop below 35% before implanting a defibrillator. However, in ACM-LV, the risk of electrical instability and sudden death is extremely high, even when the pump function is still preserved. Therefore, we consider primary prevention ICD implantation even when the ejection fraction is greater than 35%. This is a critical deviation from standard heart failure guidelines. If you see a patient with a genetic ACM profile and a normal ejection fraction, do not assume they are safe from sudden cardiac death. Biventricular arrhythmogenic cardiomyopathy is exactly what it sounds like: involvement of both chambers. This diagnosis can be tricky because if both ventricles are failing, it might just look like end-stage heart failure. Often, the diagnosis is clinched by using late gadolinium enhancement on cardiac MRI to find fibrosis in the less involved ventricle, confirming that the disease process is widespread. You must distinguish this from secondary right ventricular failure caused by chronic pulmonary hypertension. In biventricular ACM, the right ventricle is sick because of the primary genetic muscle disease, not just because it is pumping against high pressure from the left side. Next is a distinct morphological entity called left ventricular non-compaction, or LVNC. This occurs when the myocardial compaction process stops prematurely during development, leaving the heart muscle looking spongy with deep trabeculations. For NEET PG, the specific diagnostic number you must memorize is the ratio of non-compacted to compacted myocardium. A maximum ratio greater than 2.3 is the diagnostic threshold. However, be careful with this diagnosis in athletes or pregnant women, as their hearts can develop reversible trabeculations that mimic this condition. True LVNC is often associated with other genetic cardiomyopathies or dystrophies,